will be encapsulated into a summary sheet that we will send out to all of the members by March the 1st. Now, members, you need to be paid attention now, because I'm going to have some of you show up next week and go, I didn't know what was going on. So, members, if you want a recommendation considered at the March 7th meeting, I would ask that you contact the staff and the chairs and let us get it to Mr. Stevens so he can include it in that summary. Because what I want is all the members to have in their possession a week prior or close to a week prior to our March 7th meeting a list of the potential recommendations that we're going to be asking you to make a judgment on. So there will be votes at the March 7th meeting, and they will be on the recommendations that are a compilation of what we've been talking about for the first year. Recommendations, obviously we've heard what the governor's recommendation is. We have and will continue to hear what the Stevens Group recommendations are, and any member on this task force certainly has the ability to make a recommendation that they would like considered. And we will try to put those in, again, in a format that we can take action on in the next March 7th meeting. So March 7th meeting will be an important meeting because, again, that's when it's going to be time to quit talking and discussing and studying and start voting. Then there will be another meeting, March the 29th, that we will ask BLR to take those recommendations, if any, that are approved and turn them into legislation. Because as you all know, sometimes legislation doesn't look like what we thought we were talking about with recommendations. So the members of the task force will then have an opportunity to review potential legislation at the meeting the end of March. That is what we have as far as the schedule going forward. Obviously, there'll be some other items that come up, and we have a busy agenda today. And so, having said that, Mr. Co-Chair.
Yeah, thank you, Senator. So, I think this presentation that we're going to hear this morning is going to be an essential one in terms of us being able to make the decisions that the Senator just talked about. And I want to connect the dots back to kind of where we've been so we can all see how what we're hearing today is going to connect. Beginning October 7th, the Stevens Group gave us recommendations, and they're basically in 3 areas. Area number 1 is the private option Arkansas Works bucket. Area 2 is the Medicaid savings bucket. And Area 3 was other things that we can do to be more efficient, more effective in DHS and with our healthcare savings. On October 7th, with regard to the Medicaid savings approach, the Stevens Group gave us 3 different options. One was a 100% PCMH model, the other was a 100% managed care model, and the third option was a hybrid of the 2. Since then, we've had lots of different discussions. Some members actually of the Healthcare Task Force presented a PCMH-oriented program called Diamond Care. And today, what we're going to hear are what I'm going to call updates to 2 of those recommendations from the 7th. One of them is a non-managed care recommendation, which this task force asked them to do, and the other is an adjusted hybrid managed care option. So as the Senator talked about, the decision we're going to make next month, today in the walkthrough is going to be the granularity we'll need to really understand and assess that. Do we need to approve the minutes, Jim? So before we recognize the Stevens Group, can I get a motion to approve the minutes from the last meeting? A second? I see a second. All in favor? The minutes passed. Senator Rapert, you're recognized for an announcement.
To go live. There we go. Thank you very much, Mr. Chairman. Just a word, several of the members here are now members of the National Conference of Insurance Legislators, and if you do not know and not aware, February the 26th, 27th, and 28th, the National Conference of Insurance Legislators will be meeting here in Little Rock, Arkansas for the first time in I think about 20 years. I serve as secretary of that group. I know that Senator Elliott is a member there now, Representative Ferguson, Representative Kelly Link, and some others. And wanted to make sure that you're aware on Friday the governor will give the keynote luncheon at that particular meeting. And obviously, all of the issues that we've just heard about this morning will be a topic that's a chance for you to be with legislators from states all around the country to talk about the issues and some of their ideas as well. And appreciate you to go out and register at www.ncoil.org. Thank you, Mr. Chairman.
John, why don't you go ahead? You guys are recognized. Just introduce yourselves and who you're with, just for the record, and you're recognized to present your update.
Okay, thank you, Mr. Chairman. For the record, John Stephen from the Stephen Group. I'm here with Richard Kellogg, Stephen Palmer, and Rory Rickard, and also Sheila Cooper from our team is here, who will be presenting later on the EEF update. So what I'm going to do today, I just wanted to make sure that you all have the evaluation plan that we had our recommendation plan. It's not the PowerPoint, it's the Word document plan. So I know that Phil had sent that out, and so the PowerPoint is going to be actually dovetailing from that actual plan. So if you don't have the Word document before you, I think
everybody has that. It's Appendix E1, and it's in your packet.
Can I just see the cover? It's evaluation. On the top it says evaluation plan. Okay. Because I may be alluding to that back and forth while we go through the PowerPoint. But I first want to just go over today's agenda briefly, and we'll try to, again, go through as quickly as possible. I'm going to hand off when there's questions. Stephen's worked on a lot of the analysis financially. Richard has done some thorough, in-depth review with the development, disability, behavioral health area. I've worked predominantly with long-term care, trying to make sure we can analyze that area. Rory's been on the pharmacy area, and so we have different groups, and then we work together and we put our thoughts together for you. So what I'm going to do is kind of a compilation of that, and then we're going to talk a little about a few things that I need to update this task force with now on the private option impact that has come up, and then we want to talk about comparison to managed care, capitated full risk, because as we were going through this charge, the chairs sent us a note to take our findings for the Diamond Care type plan with risk, is what we're going to call this Diamond Care with risk, to give what would that be compared to a capitated managed care model. And we looked at a number of states, and one of the things we've done in the last 60 days is contact and review documents and contracts and results in states. Mainly we looked at Virginia on behavioral health side. We looked at Arizona. We've looked at Massachusetts' model. We've looked at Pennsylvania access model. We've looked at a number of models. Louisiana is a base model. We keep going back to the Louisiana model because Louisiana was one of those states that actually had a PCMH, Diamond Care risk, and managed capitated running about the same time, and they had some good comparison financial information. And obviously there's programmatic issues on every state, that there's concerns about all the models because there's issues that need to be watched and reviewed. So we're going to go through that today. So I'm going to start with the behavioral health because I want to finalize the Representative Gray's question and issue. The final analysis was two things: to look at whether there were multiple programs, RSPMI, CHMS, and DDTCS, billed on the same day for the same individual routinely. And that was one of the questions. It was just a question, and we reviewed that. It wasn't that there was any facts or evidence, but we need to look at the data. And there was also a lot of anecdotal information. So we started to review all the claims for that purpose. And we also wanted to consider the effective modifiers. I don't want to go through this at length, but we've given you a complete PowerPoint deck of our complete analysis. So that concludes our behavioral health analysis on those two issues and the other issues that Representative Gray brought to our attention, which, again, I will say, were excellent and outstanding questions to look down deep into the data to identify if there are some anomalies. And you're going to hear from the Office of Medicaid Inspector General here, who we've also met with, that has conducted at the same time an audit from their federal auditor on group psychotherapy, which is only one of the areas we looked at, and absolutely confirmed some of our recommendations and findings in our opinion. This one particular question, which we're finishing up, and here are our findings. In total, multiple claims across the 3 programs in one day represents 3% of total claims, 17 million out of 554 million. So it's not happening a lot, but it is in fact happening. 3,431 recipients had multiple claims across these 3 programs on one day. 5 providers accounted for 78% of the multiple claims across programs. And it was very difficult to determine whether it was actual abuse. We don't know that. We would recommend that be referred and to be looked at. The providers here, we're giving you the dollar amounts. The top 5 providers, you can see the amounts in dollars, and again, they add up to $17 million. And there's definitely an area where it should be looked at, and I've already spoken to OMIG. Dr. Oliver from our team is available to meet with their federal auditors, as is Richard, and Richard's been working with Department of Human Services, who've been a great partner here, and everybody is focused on this issue more than I've ever seen before in the past few months.
Is there any regulation that would be violated by doing multiple claims on the same day, or process or policy?
No, this is all consistent with policy, and it just needs to, it could be that it's overutilization, and there needs to be utilization controls. And this is why you bring forward managed care or a capitated or a fee-for-service managed care entity like the Diamond Works proposal, because you need to begin to really give the tools to the utilization review process.
Do other states have any regulation or process limitation to stop this?
Yes. Richard?
Well, there are some approaches that states can make to avoid unnecessary duplicated services from different benefits on the same day. I want to be mindful that the basic populations are kids in this area, and in terms of the DDTS and the diagnosis for the CHMS array of services, which is where these are cross-references, are in fact referred through physician referral. So you do have that factor in there. Some states in their MMIS systems will have edits for multiple billing days from different providers. The safety zone in your system here to avoid inappropriate benefit billing by a person without the right provider certification is your provider type code. So an RSPMI an RSPMI provider cannot provide speech pathology services unless they have that license and have that provider code. And that's an important factor in terms of control. Some states will look at a differential aspect of how they will approve the child or an adolescent to be eligible for the services other than just a PCP, and that's where managed care construction comes in, and as John mentioned, a managed fee-for-service at-risk Diamond Care type administrative services only vendor.
Okay, Senator Cooper, you're recognized for a question.
Thank you, Mr. Chair. John, this data that you're collecting here, is this snapshot data or is this period of time data? And if it's period of time, is there any trend that you can identify either up or down or neutral?
Yeah, 2000. It's annual data, but there's no historic. We didn't look at historical. I mean, this is a very comprehensive review.
Okay, thank you.
In your PowerPoint, it has a detailed analysis of claims in a graphic construction. And Will's findings are in that in detail, but the basic construction is there was very little pattern capacity that we could make. Number one, the number of claims, as you can see, is only 3% on the same day, and they tended to cluster around certain services and didn't see a lot of cross-correlation along that, and that's in the PowerPoint data.
Okay, thank you.
And we've also spoken to the Office of Medicaid Inspector General, who will be here testifying, and we're going to be giving them all this information, including the backup Excel and spreadsheets and the data and all the review we've done.
Okay, we got one more question here. Representative Hammer, you're recognized.
Thank you, Mr. Chair. On providers A through E, are all those currently still in business, or are any of them, did this information come from somebody that was out of business today?
To my knowledge, they're all currently in business.
Okay, thank you.
So the second issue was the lack of built-in logic to the codes and modifiers. That did not impact the analysis. The behavioral health codes are not designed with inherent logic, is what we have found, and we've talked to the department about this. And, you know, there could be reasons, but it's very complex. So what we've recommended here is a few things. First, behavioral health services claimed on the basis of service time. The agency need is $455 million, so that's a big chunk of your budget. And the agency needs better visibility and policies to avoid future abuse. The agency should have personnel assigned to review claims for questions such as these, and they lack personnel they lack really good Medicaid integrity tools, pattern technology, tools that other states use repeatedly to determine if there's outliers, and proper algorithms, and really focus on this so that, you know, if there is abuse happening, you're kind of catching it and you're not doing a pay and chase type model. And so we've said the agency should review all behavioral health claims for unusual patterns, and you'll hear more from the Office of Medicaid Inspector General on their thoughts too. Review recipient case files on sampling basis, and develop policies that set appropriate limits on behavioral health claims across the 3 programs. In our savings model, we took in consideration that some of these rules and changes and adjustments will be made within a short period of time, so that you could hopefully see additional savings. And we can talk about that later. So that concludes, again, it's very detailed, this analysis, and it's in the PowerPoint packet. If you have any questions at all, through the chairs, let us know, and we could further drill down. But I really feel that the folks we met with at the department and also at OMIG are very, very much focused on this effort now. And I don't think that we need to be as focused on doing any more analysis here, just my opinion, but more monitoring for the task force. So the next issue is something that we wanted to bring to your attention. So this is an important issue that you need to be aware of. So it goes to the heart of the private option impact, general fund impact. The governor mentioned this morning. Why he's telling you that it's a bigger impact is because there's a few things that are happening here in certain populations. And I want to go back to our first forecast in August. Remember, in August forecast, they didn't have a complete history of the actual population at the time. And we were dealing with a few populations, and if you look at where the red is here in terms of the cost, that's what I call their costs not otherwise matched. They're all, their costs that the federal government now is basically, other than the uncompensated care, the top 2, the 22, like if you look at 2017, the 22 million and 39 million, those are costs that are going to be in your Medicaid program, in your traditional program, even if you were to exit the private option. So those costs were costs that we wanted to pay attention to right up front to let you all know those are general fund dollars. So if you do exit the private option, you need to make sure you backfill some of those general funds immediately, because those populations, pregnant moms, are not going away. The law requires you to cover them. You're covering them up to 200% FPL. And SSI disability that's in the private option. These are individuals age, blind, and disabled. Some of the age population, elders that do spend down. So it's important for you to know that. And then it's important for you to know the reduction from your budget on uncompensated care. So all of this is an impact, no matter what. So we've talked about some of the general funds. We've talked about the shifting. This is just the slide, again, reminiscing a while ago where we showed you these are all the different spending impacts. Stephen recently met with Department of Human Services, who has changed their estimates. These aren't our estimates, and I'm showing you their estimates. So their estimates.
John, I just want to make sure I'm looking at the chart right, and I realize this is a refresher from October, but this is where we got down in the lower right-hand corner, the final number over the 5-year period you're looking at is $438 million direct general revenue hit over the 5 years cumulatively in your October report, correct?
Yeah, that was the August report that we did, but yes. Yeah. So that slide is just the same slide that we presented in August. It has increased. It has increased according to the Department of Human Services. We could go and further look at it, but I will tell you that there has, in our opinion, been an increase. And I'm going to show you why in a minute. So if you look at this January forecast now coming out of DHS, it's very significant when you look at some of the cost shifting in the Medicaid population. The premium tax with the private insurers has gone down somewhat from projection, but the cost shifting of the traditional Medicaid populations and services have actually gone up. And when you look at the next slide here, we asked them to give us information on pregnant moms, for example. And you can see the pregnancies, and you can see how much the births have really significantly dipped in terms of the traditional Medicaid program. So for example, if you had 24,000 births back in 13, and they're projecting now 8,238 in 16, that's a significant reduction in what those children are being born, but those services are being covered by the private option. So that's because if you sign up if you go on the private option today and you're a female and you're not pregnant, you're going to be asked the question. You'll be asked the question, are you expecting a child? And if you are, the good news for your state is the Curium system has set it up so that when that expectant date happens, you have 2 months where you're on traditional Medicaid during that pregnancy. But you have 2 months after that, and then the Curium system and the eligibility automatically puts you back into the match in the private option. So the state is getting the enhanced match right there. But on the redetermination, that question's not being asked. And those individuals, if you become pregnant after that first year, you're still on private option, and you're seeing a result of a lot of those costs being absorbed by private option here. You also have some of the age, population disability, SSI, and we did speak to the department. There's been a real reduction in the number of individuals filing for SSI. And some of them are probably thinking, well, we just want the health care coverage, and that's what they're seeing here. This is again their projection based upon their budget expenditures for those services and populations. So I can tell you with reasonable certainty, Stephen and I looked at this, that it is an impact, and those pregnancies are still happening in your state, and they're being covered. But to what extent would require us to do a lot more drilling down and reviewing and analyzing to identify exactly the precise amount. So if you go back up, and now that you see that number 637 impact, according to the Department of Human Services data, this has significantly increased from our August projection. And our August numbers, again, were based on their numbers with regard to what their historical budget looked like and projecting going forward. So, we could do surveys, we could go knock on doors, and we could do a lot of analysis here, but it'll be very costly in terms of time.
John, again, I'm always slow in the learner group, and I just want to make sure I understand this chart. So the first section really affects direct costs to the general revenue budget. And in your original August data, which was page 8 in this thing you've handed to us, the 5-year impact of the direct general revenue cost side was an increase of $130 million. But then there were general revenue helps from the private option, the premium tax and increased tax collection, and that $567 million more than offset the direct general revenue hit. But now what you're saying, that the cost shifting that we're seeing in reality now that we've got more data are such that we've got 2 things happening. Number one, the direct cost impact over these 5 years to the general revenue budget is a help, not a hurt. And then on top of that, we have a net general revenue increase from premium and other taxes. Now, notice in here that the increase from insurance premium taxes is down about $75 million from your original estimate, So it looks like we're not collecting as much in premium taxes as originally estimated, even as we're saying a bigger impact of cost shifting. And the net of those two effects is that the $200 million in benefit to the state budget that we're seeing in this most recent update. Is that a fair assessment of this?
Yes, but the premium tax, just so you know, remember that you heard earlier there was a credit you had in your state statute. And so I'm not sure the department took that into consideration, don't know. We have to do some further analysis. So, you know, that's one issue I still want to look into.
Hey, John, let me see if you can clarify something. So you're basically saying that because of recent reassessments of the number of pregnancies that are now being covered on the private option and other transfers from traditional Medicaid to the private option, it has a greater impact on general revenue. And I understand that mathematically. What I'm having trouble with, that would by definition mean that the total size of expenditures for the whole private option program would be larger, right?
Yes.
But when I look at the two charts there, on page 10, it says 2021 is 2.15 billion, and on page 8, it still says 2.15 billion. So it still shows, I guess what I'm getting at is it seems that our 10% match requirement would be larger also if the size of the program were all larger.
In this analysis, we're still using the projections that one of the agency's consultants put together, Optimus, their actuarial consultant. And so those numbers have not been updated to reflect the latest enrollment in the private option.
So this isn't really accurate then? I guess what I'm saying is you can't say that it's saving more money because the program, more people have been put on the program without also taking into account the match.
These reflect the overall estimates from the department based on the full fiscal year 15, which is a difference. It's an additional 6 months of data. I need to double check as to how the private option population is contained in these numbers.
Yeah.
But the net effect of that would then be if in the future you were projecting these costs in traditional Medicaid, so in that chart which compares our match on traditional Medicaid and our match on the private option, if that chart has not yet been updated, it would understate our match on the private option, and it would dramatically overstate our match on the traditional Medicaid program, because we're effectively transferring 30% match cost to 10% match costs, and we haven't gotten yet to the part where we look at the overall programs and adjust both of those numbers. Traditional Medicaid projections down and private option projections up because of the cost shifting of where the people land. So that doesn't really have anything to do with the accuracy of these numbers.
Yeah, I agree. I mean, again, we requested from the department, by the way, a couple weeks ago, the most updated eligibility numbers for the private option. We still haven't received those. But these are the department's forecast numbers. So yes, we can go back and do further analysis to compute.
I guess I think there's some confusion, at least on my part, how you can change the bottom end but not change the top end. So we can take a look at that. We've got 4 people on the list here, so just keep that in mind. Representative Farrar, you recognize.
Thank you, Mr. Chair. John, can you explain to me the increased collection from economically sensitive taxes, 4%? What, I mean, kind of tell me what that is. It's on your chart on the impact of state revenue. It's $360 million over 5 years.
And Stephen, that's the macroeconomic impact that we had done early on in our analysis, I believe.
Correct.
Okay, so you're
Kept it
so
the
you
same.
think you will get 4% more on your taxes for the more money we're spending? Is that
Correct. Yeah, it's approximately $1 billion of additional federal funds that's coming into the state for this, which creates additional tax collections.
Why 4%? I mean, is there?
That's a number that the agency had used in the past, and it roughly corresponds to the overall state tax collections against the GSP.
Okay, all right, thanks.
Senator Ervin, you recognize.
Thank you. Just follow up on the premium tax. You said that you didn't know if they took that into consideration at what point, like from the onset of the program or through the middle of it? I was just curious.
Go ahead.
were we counting on X amount but didn't take into consideration the state statute? And so,
Yeah, my
could
understanding.
you just elaborate on that?
Sure. My understanding from the agency is that the initial premium tax collection projections were based on projections that came from DFNA, and they had not taken into account the credits that were in the statute at the time, which have now been changed. And so some of the historical, or some of what we have now seen in terms of the historical experience over this period of the private option so far was reduced in terms of the premium tax collections. And going forward, it's adjusted somewhat.
Did you look at that state statute as to if that was in place at the onset?
It was not, and that's
was not?
part of what I'm saying is that the initial DFNA projections were from prior to any collections, and once collections started coming in, they were coming in at substantially lower than they had anticipated,
Right.
and that's about the time that the state statute was changed.
So after the private option was put in place in 2014, then came a premium tax credit.
On that point, I believe that the premium tax credit was already in place, but there was a statutory change that changed the way it applied to the private option.
Okay, I would like clarification on that, just from BLR perhaps. Thank you.
Senator Sanders, you're recognized.
Thank you, Mr. Chair. I was wanting to go over and explain just a little bit better sort of the shift that's occurring, and it's not just the pregnant women, but all the other programs on the preceding pages.
Right.
Those were paid out prior to 2014. We paid a 30% match on those, and it varies, but that's where we're at now, 70-30. Now those programs have been eliminated, and they are going into the private option. Therefore, for instance, pregnancies, we're paying at 100. Those are paid now at 100%. In 2017, we will pay 3%, and that will finally go down to, when we pick up in 2021, we'll pick up our full 10% requirement. But that's the shift. So that's what's happening right now. What the department projected, they projected that the savings from shifting would have been lower than what it actually is. So what we're actually seeing is that the savings from the shift is actually more than what they anticipated.
Correct.
All right. Just want to make sure that was clear. I think.
And I think if you look at all the population, the medically needy, age blind in this slide, SSI, pregnant women, I mean, SSI is one that is a large part of that. I think it's somewhere around $30 million. So, I mean, it's pretty significant.
So when you actually look at, the real number, and then you kind of work down the number, you can even take out the increased taxes. You can take, there's the other things that you can take out, and you can do a straight comparison of the shift. Even it gets us really close to, much closer to our match. I mean, so you're seeing, this is obviously some benefits. I mean, I think we want to see there are other things within the program that we want to see happen in terms of behavior and outcomes, but I just wanted to make sure that was clear.
Yeah, for the purpose of this meeting, we focus mainly on getting the report to you on the savings for the $835 million. This came up because it was recent discussions, and I wanted to make sure that you all saw, and we had a meeting with the department to get their numbers so we can get them to you. And we haven't dug deeper. We could, and we could do some further analysis for you. But it is a pretty clear, reasonable estimate that you're probably looking over $100 million general fund impact now, just based on where those numbers are, on just the general fund component that you've cost shifted into the private option.
Representative Gray, you're recognized.
Thank you, Mr. Chair. Just got a question. It's back to kind of what Senator Sanders was talking about with the increase in the cost shifting. So in like 4 months, we went up $52 million for 2017, which is like 150% increase. So I have a hard time thinking in my mind that that's just pregnancies. And I know we end up, at some point in time, we are going to go to a 10% match. If we did not have Arkansas Works, no expanded Medicaid in the future, those people, 0 to 17% of the federal poverty level, will go back to traditional Medicaid at the 30% match. right now, we're paying premiums, what, 600 something a month? How much are the premiums that we're paying for these members each month that when they go back to traditional Medicaid, we would not have to pay? Is that being taken into account as well? So it's really not 30% versus 10%. I mean, does that make, do you understand what I'm saying?
Yes, I do. I mean,
Okay.
Stephen might want to elaborate, but I just want to make sure, the pregnancies are only about 20 some odd million of that, or 20, a little more than 20 million. The SSI is somewhere around 35, 40 million. I don't have the exact numbers. We don't have the spreadsheet right out now, but there are other populations, as Senator Sanders says, that's in there. So the pregnancy is a large part of that, but it's
Okay.
not
All
the
of
vast majority. But go ahead, Stephen.
No, just on the point on the difference between, or comparing claims payments to premium payments, the premium payments are actuarially based, and so in the aggregate, the claims payments that are being made for a certain population will be approximately equal to the claims payments that are being made for that population.
Okay, could you elaborate, I'm sorry, Mr. Chair, one last question. Could you elaborate on the SSI part, how that falls into the Medicaid expansion?
Yeah, so one avenue into Medicaid eligibility is through a Social Security disability determination. And what we have actually seen is, like in the pregnancies dropping, the actual number of enrollees in Arkansas Medicaid that have come through that SSDI door has dropped.
So can I?
Hold
I
on,
wanna
now
make-
I'm even more confused now.
I want to make sure I understand that point as well. So in the past, we had X number of people in Arkansas, X number of them were getting to a certain age, and X number every year were signing up for federal SSI. When you sign up for federal SSI, you get a check from the Social Security account of the federal government. And what you're saying is, if I heard you correctly, is 5 years ago, we had, 10 people sign up for SSI, then 9, 8, 11, numbers in that range, and then all of a sudden, it's dropping noticeably, statistically, significantly, and your theory is that instead of signing up for SSI where they get a check and Medicaid, they're just saying, heck, all I really need is the health care, so I'll go into the private option and forget about signing up for SSI?
Well, no, the financial part and the disability part of Social Security are independent, so they can
Pull your mic a little closer there,
I'm
Wade.
sorry. They can still be getting the financial part of SSI, even if they don't go through the disability determination. Going through the disability determination, though, comes with additional financial component, but then also Medicaid eligibility. So yes, what may be happening is they may still be getting their normal Social Security check, but then just deciding that really what they need is the health care, and they can get it on the private option, and so they don't even go through the disability determination. But this is what John was alluding to in terms of additional data collection. That's our theory. The numbers have empirically dropped.
Yeah, and if I could just add, again, in order to get the clear, what Representative Gray's question is a good question. That's why I was actually thinking, reluctant to even, should we present this, but then, it is actual historical trends they're seeing dropping. So it's beneficial to do further digging, but it's going to take some, that's not an easy task. I'm just to let you know. But your question, Representative Gray, is what we had talked about in our group. But I think it's worthy of at least making sure, one, that you all are very much aware of this.
Okay.
Representative Gray, you're recognized. Continue.
Thank you. And just one follow-up question to that, just help me understand this. Are we talking SSI for children? Because if you go through the disability process as an adult, you have Medicare. Is that correct? That's correct, right? So we're only talking about SSI for...
No.
That's one of the main avenues through which, or one of the main eligibility avenues through which people come into the DD services. And so that could be part of it. But again, we haven't looked at the underlying services or diagnoses.
And it could very well be some adults. I don't feel comfortable answering that question. Again, I feel comfortable presenting this, and I think DHS should be asked some of these questions.
I agree, thank you.
But I want to make sure because they presented this to the governor. It is part of his analysis as well, and they feel strongly about it. I want to do some further digging on it.
Thank you. I recommend we ask some of these questions to DHS.
Yeah, Mr. Seelig, do you have anything you'd like to add to this, or anyone from DHS who helped put these numbers together?
I can add some now or later, whatever.
Here, well, I guess what I'd ask you to do is be thinking about that, because I have a fundamental problem with the way these numbers are done here. We say there's a lot more cost shifting savings because more people are on this program, but that yet we say this overall size of the program is the same, and I just don't see how the math works there. So if you could kind of think about that, and when you come up for the other section, we'll have an opportunity to ask questions on that. Is that okay with members? All right, we've got 1, 2, 3, about 6 more on the list here, so try to get to the point. Senator Cooper. I'm sorry, that's Senator Senator Stubblefield. You're recognized.
Thank you, Mr. Chairman. John, could you educate me just a little bit more on this premium tax? How much revenue are we talking about as far as the premium tax?
Right now, it's averaging about $22 million a year.
$22 million a year? Has Congress ever voted on a law pertaining to the issuance of a premium tax? And the legality of it?
I'm not sure if I understand. That's part of your state's tax structure.
Well, there was another state that is being in litigation right now for charging a premium tax.
Oh, okay.
On Medicaid expansion. You understand what I'm saying?
Now, I think you're mixing up. There's IGTs, there's other provider taxes that are at issue at CMS all the time in states. And so you're probably reading articles about states that have actually gone beyond the limits, and some of them use the receipt tax. They put different expenditures in receipt tax, and it can equal a lot of dollars.
And return that money back to?
Correct.
The insurance, the providers?
That would go to the general fund. It would be states trying to game the system, is what you're seeing.
Okay, one more question on this SSI. Is it possible that some of these people could be foregoing their Social Security to keep their insurance, as far as the limits on their income, what they make?
I mean, it could be a possibility. And that, we've got to do some further analysis. When I saw this, it was, that immediately popped up to me, but I don't know the answer. I can't answer that. That's going to require some very detailed analysis.
That's all I have, Mr. Chairman.
Okay, Representative Bentley, you're recognized.
Just a quick question. I'm sorry, my handout does not work. I could read it eligibly. Can you tell me what the percentage of births in Arkansas are being paid for by the private option and Medicaid together? What's the percentage of live births? And if I could read my form better, I could figure it out, but I can't. Thank you.
We can get that for you. I mean, Medicaid, if you look at the slide here, it's without percentage. We didn't do the percentages, but you've got, for example, in 2013, 37,000 in live births in Arkansas, and you had 24,000 of those were paid by Medicaid, were Medicaid births. But I mean, I'll get those percentages for you. There were actually 24,000 were additional Medicaid births. So you're talking about a substantial amount. You remember the federal law allows for up to 200% FPL coverage. So, you're covered, and the law allows you to be covered for a certain amount of time after delivery for your medical costs as well, and that's all covered by traditional Medicaid.
Okay, thank you.
So anyone that's up to 138 or 135 actually now, going forward, Medicaid is going to shift that into the private option. And if they do it at the time of eligibility, if they say at the eligibility they're not currently pregnant, they're in the private option. But if they become during that time, and this is where the redetermination becomes an issue, you ask the question on redetermination, which is supposed to be asked, and that's why, and then there needs to be coverage for traditional Medicaid, and then we go back into the private option. So your state has done a pretty good job on the front end. It's on the redetermination they're working on.
Representative Ferguson, you're recognized.
Thank you. I have a question about the 90-day retroactive eligibility and what the actual savings would be on that. I know it sounds good, and I know it's one of the governor's proposals, but just from a personal experience, our office does OB ultrasounds for the health department. So, and they come in and they are put on Medicaid pending and retroactively pay for the OB ultrasound. So if you eliminate the 90-day retroactive payment, you're not eliminating the payment. It's just now that the health department is going to pay it at 100% state money instead of it being 100% federal money. So I'm wondering how many of these retroactive payments are actually going to be picked up at 100% state money instead of retroactively being paid with federal money. Do you have any numbers to support the savings for that?
No, I don't. We would have to look into that. That's a good question. I don't have the numbers.
Yeah, you see what I mean?
Yeah.
I mean, it sounds good, but if we're going to be picking it up as a state instead of paying it with federal money, does that really make sense?
We can look into that.
Yeah, and I might say, Robin Lundstrom and I, passed the unplanned pregnancy bill just as a note, and according to Health Department, when our last meeting, it was about 70% of the births in Arkansas are Medicaid. So I'm hoping that with our education of young people for unplanned pregnancy, that we will start to reduce the number of births for Medicaid, and in turn reduce the number of children that we're supporting through Medicaid health care.
And I think the 70% is pretty much confirmed in the analysis we have.
Representative Farrar, you recognize.
Thank you. This may be a DHS question. If the private option ended, how many people would go back to the traditional Medicaid system? What would be the increase prior to the private option to now, today? Would it be 100,000 extra people? Because there's the cost that you're actually going to attain, not counting the pregnancy and the ESPD T population. Do we have a number on that, or is that a DHS question that we need to know?
I'm not sure did you see the population number?
We haven't cut the data in that way, but we can. What we have done so far is just on the financial side, which sort of includes the head count.
Right, because we're going to be comparing back to pre-private option. The population is actually going to be a lot more, a lot higher, because we put a lot more people onto the system. Now this population will go back to the traditional Medicaid at a cost of 30% match instead of a 0. And I don't know if we're figuring it that way, because that's, if it's 100,000 people, you're looking at $1 billion. That's $300 million extra dollars compared to if they go back to the traditional Medicaid.
If you look at it, you could look at it this way. If you look at slide 10 here, if you see just take 2017, the first year, you see your $21 million is state fund savings from optional waiver programs. Okay, and then you add the next one is 91 million, is your pregnant women, SSI. If you really think about it, those two numbers are populations and services that if you were to say no to the private option today, you would have to have general funds to cover those services and populations. So based on your question, if you focus just there and you say, okay, the 37 million is reductions in uncompensated care, that just comes because your budget in the past had $37 million in the budget for uncompensated care. When the private option came around, that went away. So we're assuming that goes back if private option goes away. You could say, no, we're not going to do anything on uncompensated care. But that 91 and 21 is pretty much, the question is, that it represents a population in services, and we don't have the number, but we do have the finances. You could say, it's over $100 million general fund impact right there.
In one year.
In 1 year.
Right.
That's
so
general
in 5
5
fund. Years, that's $500 million, $500 million, 5 years.
You can see the numbers right here.
Okay. Thank you.
Senator Sanders, you're recognized.
Mr. Chair, about to you and Representative Collins' questions about the top line numbers in terms of the private option expenditures and all funds. That's based on two things. It's based on enrollment numbers that have been steady. From I think the initial projections that we've had, it's always been somewhere around 230 to 250,000 people potentially, and built into those expenditures are the payment of premiums and some level of increase. So that number, those numbers at top actually may not change that much at all, because that's sort of, it's actually some of the case that the governor was making about some managed care, being able to project forward on a capitated basis, looking at what you're going to be paying out. So that's probably not going to change that much. It's sort of what's underneath the hood of what's going on is that essentially what has essentially changed. But I mean, I think that John or someone could
we can get those.
But I mean, is that right, John? I mean, so what
I requested a few weeks ago, because John Martin actually asked me if we had those numbers as well, to get you the current eligibility numbers. I'm waiting for those.
No, we're still talking about the same universe. We're talking about the same universe of people, and then we know we now have historic numbers on what premiums are and maybe what we would project them to be. So that's really not going to change that much.
All right. Again, we've about beat this horse to death, so I won't spend a long time talking about balanced equations. The only thing I'll say, David, is if you look on page 10 and page 8 on pregnancies, when you take it from 26 million or when you take it from 47 million to 111 million on the bottom end, and we have a 10% match, mathematically you can't say I've got a lot more expenditure, and when I'm required to do a 10% match on the program, there's no impact. We're not talking about number of people or size of the program. We're talking about mathematically you're saying we're going to have more savings because more pregnancy costs are transferred to the private option. I accept that. But what I also think you have to accept is that also means the size of the program is going to be larger and our 10% match is going to be greater. That's the mathematics. Okay. All right. I think we've that's our last question, and we pretty well have slaughtered that chart.
Maybe I shouldn't have shown it to you all, but
no, I think you have to, because the reality is everybody says anybody can use anybody's numbers anywhere, and then you can just have any decision you want to have based on what your gut says. And the reality is we have to get to alignment on somebody's numbers. One of the reasons we're paying you guys is to be that objective arbiter. So what I would recommend, John, is, because I believe that Senator Hendren is right, there's a certain amount of money that is spent for Medicaid, and there's a certain amount of money that's spent for the private option. And there are projections for how many people and how much money is going to be involved in that. And if something shifts in our projections from one program to the other, it has lots of cascading effects. But the totals, including that total up above, and the total for the Medicaid projections should also be shifting to reflect those changes. So what would be helpful to me is when you update this chart, and you update the total private option expenditures line, which is the very top line, if you could have a total traditional Medicaid expenditures line below it, and that way going forward, whenever we talk about shifts between one program and the other, we will also see those totals happen. Now, my projection is that when you do that, just as Senator Hendren predicts, the state match on private option numbers will go up for every single year, but the differences will also go up so that your net numbers will come out similar to where they are with the 600 million plus if everything else stayed the same. But it will more properly and accurately in a balanced equations way reflect that on this one chart. And I think it'll be important so that people can see that there's nothing wrong with the numbers, it's just which numbers are you reflecting on the chart.
Correct. We'll go ahead, clarification.
Yeah, I have had a chance now to dig into the numbers a little bit on it. And the key issue is that within the private option, the projections that we have here for private option expenditures were based on the original structure of the private option. And that hasn't changed. But what has changed is the empirical result coming from traditional Medicaid, where we are just seeing lower cost and lower enrollment in certain eligibility categories, which we then theorize is based on those expenditures getting picked up in the private option.
Yes, and I'm just making Senator Hendren's point, which is that theory, like squeezing a water balloon. If you're squeezing this side of it, it's got to go somewhere. It's got to go to the other side, just as he's suggesting. And if we're updating the heart of this chart, it's worthwhile to update the top line as well, so that it has the internal mathematical consistency that keeps its credibility where it deserves to be.
Well said.
Okay, we're on slide 13, I think, right?
Yep, actually 12. We'll start with the charge. The charge is to find at least $835 million in savings without a capitated full-risk managed care, with the exception of dental. But I'm going to highlight the at least right now because that was the charge, at least. And so we were looking at about $1 billion to try to identify $1 billion, which we thought would be off of that 5% growth rate would be a good benchmark target for us. So what we're going to show you is that was our baseline that we used internally. And that is without the capitated full risk plan. We talked about the guiding principles, and it's all in the report that we had given you a lot about our plan. So I'm going to go through this quickly. If you have questions, just stop me. But the model itself really looks at Diamond Care principles. Medicaid fee-for-service payment stays the same, so you're still paying fee-for-service. You've got the PCMH model in place for all populations. You'll promote wellness and telemedicine. All of this will work within that whole framework. Managed fee-for-service is the key. And it's important for you all to understand now. Now we're getting into the difference between, you're going to hear this term a lot now, probably in the next few days and weeks as you begin to consider votes. Managed fee-for-service is the ASO, Administrative Service Organization type plan. You're still having the state pay the claims, and you're not doing a PMPM on a capitated manner, which you would with a capitated managed care. So that's the Diamond Care type model, managed fee-for-service. You still need an administration to run it. You still need to look at utilization. You still need to make sure you have prior authorization. And we're adding independent assessments to the high costs, and we're focusing on high costs because that's what you've all decided you need to focus on. So there's a range of those options in the development disability, behavioral health, and the long-term care area. What I want to say, and I want to make sure everybody here understands, we were so impressed as a group with the providers. The Development Disability Association and their provider groups, the behavioral health provider groups, and the long-term care provider groups, all after Representative Collins charged to meet with us and met with us repeatedly and developed detailed plans to hopefully be a part of a report to achieve the governor's mandate. And when we work in a number of states and look at different, it's unusual that providers would come forward with detailed plans to reduce the amount of revenue that they're getting. It's unusual. And I just want to commend them. We do think that all of their plans can work in a managed fee-for-service environment or in a capitated full-risk managed care. So even in both environments, their plans can work. What we would say on the outside is hold their feet to the fire then. If they've submitted the plans and they've bought into it, and there's a lot of planning that probably needs to happen subsequent, but the baseline numbers that they've agreed to are pretty much in our savings model. And I think that is unusual too. So I know everybody's ready to work and get going, putting it together, but the first thing I want you to understand is managed fee-for-service and capitated full risk, all of their plans can fit within, okay? With the exception of the nursing home area, and we're going to talk about that in a minute.
Okay, before you move on, we got a question. Senator Stubblefield, you recognize.
Thank you, Mr. Chairman. Thank you, Mr. Chairman. This is just a quick question, John. There's a lot of talk about uncompensated care. Is uncompensated care numbers, are they based solely on the actual enrollment of the PO? Are they based on, if we still have a large segment of people going to the emergency room that are signed up on the private option, how is that calculated into uncompensated care?
So, and you're referring specifically to the tables in the previous slides?
Right.
For the uncompensated care line in those tables, that it has to do with uncompensated care costs that are directly paid for by the state. Was some of that came out of UAMS, some of it went to some other pots of money, but that is not the general uncompensated care that is borne by hospitals.
So the uncompensated care numbers you're giving us, they're not based on the actual people who are enrolled in the private option? Is that how you're basing uncompensated care, the definition of it? Is by the enrollment numbers?
John, can you talk a little bit about if somebody's on the private option, do they have any uncompensated care compared to someone who's not enrolled in any health insurance, and do they have uncompensated care? That may help explain the...
What I'm saying is if they go to the emergency room and they're signed up on the private option, and that charge is going to be much greater than if they went to a general practitioner or a primary care physician. How is going to the emergency room calculated into the uncompensated care provision?
Well, if they're...
I mean, is it based on the total enrollment, just on the enrollment, or is it the actual use of that insurance?
So if they're on the private option, then their healthcare services will be compensated, and that will not be on the uncompensated care side of things. If they're not on the private option, if they are uninsured.
But if they went into the emergency room and were asked if they had insurance, even though they were signed up, and they said, no, we don't, and they go ahead and treat them like they have to, then there's no way to determine that, is there?
For sort of true uncompensated care that's borne by the hospitals, that is not on the state's books, so that's not part of what we have.
Well, the reason I ask you this is I've talked to a number of doctors who work in emergency rooms who say the numbers in the emergency rooms are just as large as they were before. I mean, we've got just as many people coming to the emergency rooms as we did before the private option was passed. And so I was just wondering how that figures into uncompensated care.
And that is consistent with some of our previous findings that from the claims analysis, these people are using the emergency room at a higher rate than sort of people who have historically had health insurance. Which speaks to a need for additional education and outreach about proper use of healthcare services. But what we are hearing from the hospitals is that their uncompensated care costs that they bear are down since the private option came along.
Even though that visit to the emergency room is much more expensive than going into a primary care physician.
But they're covered now.
I understand that.
Let's go ahead and try to keep pressing through here.
I
mean, we did some further review and analysis of uncompensated care earlier, and we could probably provide you with that. That was in our October report. But right now, the focus right now is to make sure this task force understands.
I apologize. One of the things I personally was confused for a very long time about the difference between two animals. So my own confusion took me a long time to undo. There's emergency room care and uncompensated care. Uncompensated care virtually all happens in the emergency room. So there's a very tight linkage between those two things. However, not all emergency room care is also uncompensated. If a person has insurance, whether it's employer insurance, private option insurance, Medicaid, etc., even though it's emergency room care, it's not uncompensated. But uncompensated care is associated with emergency rooms because if you have no insurance at all, that's where you go for all your care. And those are some confusing concepts, but they're broken out in the way you guys break these numbers out, where the uncompensated care is not for anybody on traditional Medicaid, private option, et cetera, but only for people without insurance.
Yeah, and I think if the reference is to the budget, the numbers, this state in the past has put a certain set of money into the budget for uncompensated care. And that's what that number is. And that number has been removed from the budget when the private option was passed. And so that was the issue that we raised today. So let's start. We're gonna go quickly on the different populations.
Hey, we got one more question. Senator Ervin, you recognize?
And not to beleaguer this, but just I would like clarification because that uncompensated care does not go to all emergency rooms, correct? It only went to UAMS and not all emergency rooms in every hospital across. I mean, I just think that we just, if you could just provide some clarification on exactly what that expenditure and where it went for us, that would be appreciated. Thank you.
Absolutely. We'll get that for the next meeting. So when we break down this model for the different populations, you got the three high-cost populations, really: development disability, long-term care, and behavioral health. And we also have a population here that we've we're moving forward on recommendations. That's the high-cost populations that comes out of your PCMH program, but it's actually not in the program today. There's certain rules and there's cap spending and certain high-cost traditional populations, maybe in children population, that's not in your traditional high-cost ABD population. So those need to be coordinated, and that management entity would coordinate that care as well. So looking at first development disability, real brief, this is really very detailed in nature, but really for the purpose, if you have any questions, independent assessment's key. There's a different tool that we're recommending that we met with the providers. It seems to be something everybody accepts as long as it's a standardized instrument tool. That's going to be really important. And again, that could happen in both scenarios. Individualized person services, individualized service budget, facilitation of persons, providers' choices, include family members, circle of support members, coordination of a case manager on a regular basis. The issue of case management might be one that you need to look at. Is case management going to be with the entity? Are they going to subcontract that out? Or in a capitated model, usually the case management would stay there. So that's something we did financially model, as you'll see. There's more on the DD issue. The bottom line is, I guess, and I don't want to go through this in detail, but the providers here in their responses I've included as appendix. You can go through every detail that they've responded to. And what the important elements are is that they've agreed that there needs to be more controls on the spending in the waivers. And this does not include HDC. And I want to make that clear. So HDC is not even included in any of our savings estimates. So you're only talking about the population on the waiver today. There would be more support, hopefully, from family members as well, but the waivers are going to have to change, and this gets into the more global 1115 section waiver we talked about. And this is all in your report. We get into behavioral health, and I don't know, Richard, if you want to kind of summarize some of the behavioral health changes, but these are significant changes that need to be done to RSPMI and also to your children's program and some of your programs we looked at today. So I'm going to let Richard talk about that.
Briefly, we recommend that the RSPMI benefit be revised so there no longer is an RSPMI benefit, that the benefit structure for serious and persistently mentally ill adults be separated from the benefit structure for mental health services for children with serious emotional disturbance and related conditions. There are lots of state models on that. We would also recommend that the state look at the diagnostic codes that are going to be approved under this. Most states will approve a certain level of diagnostic codes based on severity for adults and children, and then other Medicaid recipients have mental health issues that are of less intensity, they use clinic option services in normal traditional Medicaid. That's what we're recommending. We're recommending independent assessment. There's been a lot of controversy about this. How much money is it going to cost? Is it going to save money? We have no doubt that it will improve your program and make it more efficient. We're specifically recommending the use of the locus for adults. People will argue about this. There's lots of states, there's a lot of research behind this, and certainly the CANS for children, your child welfare agency in this state is using it. There's a lot of compatibility. Other than that, we're looking for the benefits manager, especially for this population, to work closely with the enhanced care coordination element of this program that John will speak about in a minute.
I think in behavioral health, if there's any questions, either you want to ask them now, you can hold them until we're done. We're going to get to the finances, and we'll go through that. The enhanced coordination, I want to focus on that because this is your high-cost population, too, that sometimes we looked on. I think Senator Hendren, the first question he asked was, give me the numbers for the top 300 utilizers. We started to look at that. When you start dissecting those numbers, you see a lot of those individuals are not in your long-term care, development disability, and behavioral health area. And some are in the behavioral health in those codes, but some of them were children, neonatal, and some of the areas that you could probably do intensive coordination of complex cases and actually drive additional savings. So we want to make sure that's a part of this whole Diamond Care type recommendation. And so this is what really connecting to your PCMH health home and making sure that those populations have the same type of enhanced care coordination, though, enhanced, with the management entity working with your PCMH health home as well. And this could be done through predictive analytics. They have IT solutions that can actually cull out from the databases when these episodes happen, and then they can intervene. And that's important.
The only thing I would add, John, thank you, is that there are clinical standards that states use to identify this particular population. For instance, 3 inpatient visits a year and 3 ER visits in a 12-month period of time in the state of Virginia gets you into enhanced care coordination.
And so again, this is a population we really didn't talk about. I mean, we always talk about ABD, age, blind, disabled, but it's one that's really important. It's high cost. So this will help drive down some unnecessary spending as well. Nursing home. I want to now talk about the nursing home. The one thing I would say is we received some data from the department, and we met with the nursing home industry. We met with the department. We tried to look at some of the way that the level of care is done with the nurses in the nursing homes. So this is all going to culminate into, you know, when the governor said the nursing home industry was presenting him a plan, we were asked to evaluate that plan. If we felt that our recommendation to the task force, should we feel that that plan could achieve the $250 million savings. That's what this is going to be about, these next slides. I want to first compliment the nursing home industry as well. The report is you have. I got to honestly say I was skeptical at the beginning looking at the numbers, but they have been very forthright, and they've come up with some great plans that I think would definitely achieve the $250 million in savings. And we're going to talk about them. But I want you to see the history. There's data that requires something to be done. You've got a level of care assessment. You've got intermediate 1, intermediate 2, and intermediate 3 basically in your state. And intermediate 3 is your lower level ADL and assistance needed for nursing home entry. Intermediate 1 is the highest entry. And then you have, obviously, you have skilled nursing too. But when you start to look at the numbers, the nurses, remember, in the nursing home under 703 are actually doing the assessments. So when they categorize where they are, you're at level 1, 2, or 3, then it goes to DHS, and the DHS nurses put it into their system. And they approve the 703, basically like a second approval. But the nurses at the nursing homes are doing the assessments. And you can look at the numbers here. In these recent numbers, this was up to June of 15. We looked at all of the data. I have it here. And roughly over 7,000 are in intermediate, are in the 3 level. Over 7,000. Now, we brought that number up to the nursing industry, and their feeling is that there could be issues with the data collection at the DHS area. And we asked the DHS folks, and their nurses don't feel they're making data entry issues, or there's not data integrity issues at DHS. So at the end of the day, it really doesn't matter, because the plan that they have proposed will actually help take a lot of the population that's currently in the nursing home and transition them to the community. But the bottom line here is there are currently over 7,000 that are at that intermediate 3 level today in Arkansas.
Okay. I think there may be some questions about this, and so what I'd like to do, I think this is a good time to take a break for lunch. We're going to go ahead and break. We'll come back at 1:30 after lunch, and we still have quite a few items to cover. So members, we are adjourned until 1:30.